Hi, my name is Dr. Danielle Crane. I'm a clinical psychologist and I'm going to be answering some of your questions today. Do you ever judge your clients? So I can see why people would worry about this, but in reality, we don't. We find that firstly, we've heard everything before. Like, there's very little that you're going to say to us that is going to shock or surprise us. We get told all kinds of things. So we won't be surprised. And in terms of kind of judgments, like, we really strive to be as non-judgmental as possible. And because with our clients, we're always going to do some form of assessment to start with. We will know kind of your history and the experiences that you've been through and the way that you were parented and, your coping styles and why you have those particular thoughts or those particular emotions, or, why you're engaged in that behavior and that sort of thing. So we have plenty of information about you, and we use that information to try and understand you and to try and help you to understand as well. So we do something called formulation, where we bring all of that information together to make some sort of sense of your difficulties, and that can be written as like a summary paragraph. It can be drawn out as like a map that shows that you had this parenting experience and these other experiences, and they kind of combine to lead to these particular thoughts, and almost like a flow chart. So we will pull all of that information that you've told us together and help you understand your behaviours, or your thoughts, and help us to understand. And that means that because we have that understanding, we're not going to be judging you. We're going to be understanding those things that you're struggling with and wanting to help you with them. So I've worked with people who have been violent, and I can understand that why they're acting that way, and that it's there's very good reasons why they've kind of resorted to those particular behaviours, and I'm not going to judge them for it. I'm going to try and work with them and support them to come up with more helpful behaviours, or people who've done things that they're very ashamed of. My goal isn't to judge you. My goal is to help you to understand why that happened, and to realise that often it's the case if you weren't actually to blame, or that your behaviour made sense at the time, and that sort of thing. So we don't tend to judge clients. We tend to be as understanding and supportive as possible. And there's very little you can say that will surprise us. So please do feel free to share anything that you want to share, and to be as open as possible in your therapy sessions. The next one is, have you had therapy yourself? Yes, I have had therapy. I think most psychologists I know have had therapy at some point. In fact, it's on many of our courses, it's recommended. So when we're training to be a therapist, they say that, well, actually, it's good for you to have experience of being on the other end of therapy, being, a client in therapy, because it means that you then understand it from that perspective, and you're more likely to be empathetic. If they're nervous during their first session, or if they're struggling to keep up with the homework, or, things like that, you are going to be able to reflect on times that you've had therapy and you've struggled with those same things. So I think it's quite common for mental health professionals to have had therapy. It often makes them better at their job. And the other thing to note as well is a lot of people are drawn to mental health services to working in them, because they've had previous experiences with mental health difficulties. So either they've suffered from mental health problems, or they've had family members struggle, and that's kind of what makes them want to go and help other people with similar difficulties. So you will have, lots of mental health professionals have needed therapy at some point. Also, because we understand it, we see the value of it, and we're more likely to reach out and ask for support if we need it, because we know that therapy works. So yes, I have had therapy, and I think most psychologists I know have had some form of therapy at some point. Why do I have to do stabilisation before trauma processing? So we would generally recommend that if you've had some sort of traumatic experience and you're struggling with perhaps nightmares or flashbacks or dissociation, or you're just really anxious and on edge the whole time, that you learn what we call stabilisation skills, or sometimes we call it resourcing, where we make sure that you have plenty of skills to manage those symptoms to the point where you can kind of feel reasonably stable, before we then move on to the second stage of trauma focused therapy, which is the kind of the processing work. And that's because if we jump straight into processing without giving you any coping skills or resources, you're likely to really struggle with that. It's likely to increase your symptoms. It's likely to potentially make it so that you're unsafe, if you start self-harming more and that sort of thing. So we always want to make sure that you have the coping skills and you have the resources, so that when difficult things come up in processing, you can manage those things, and you're not going to get completely overwhelmed by that part. And it can really frustrate people, because I think from their perspective, they think, well, talking about the trauma is what I need. I want to jump straight into that. Like, I don't want to learn these skills. I want to be able to talk about this experience, and they'll get frustrated with us that we're not going to jump straight into it. We want them to learn the skills first. But it is, they are the recommended kind of steps of trauma work, and they are much more effective. Your processing is going to be more effective if you've done really good resourcing or stabilization skills first. So whilst it's frustrating, I hope you can see that there is a rationale behind it. It's not just an arbitrary thing. It's something that is really important as part of having effective treatment. Our next one is it possible to do the doctorate in clinical psychology while having young children? So I'm assuming this question is perhaps from an assistant psychologist, or someone who's hoping to work in psychology in future and is trying to work out how to manage family life alongside that. So for those of you who don't know, most psychologists will have done an undergraduate degree, and then potentially a postgraduate diploma or a master's, will have gained plenty of experience working in mental health services as support workers, assistant psychologists, those sorts of roles, before they then apply for a place on a doctorate in clinical psychology. And the doctorate lasts for 3 years. It involves a lot of work, so you have to attend lectures, you have to complete assignments, you have to do research projects, you have assessments, so things like you might have to do a therapy role play whilst you have a panel of people watching you and you're being video recorded, things like that. And alongside all of that, you also have placements where you will be working in different mental health teams, normally for like 6 months at a time, and having to see clients there and that's the thing. So it's a very intensive program, and I can understand why people would worry about completing that whilst having kids, but it is possible. So when I started the doctorate, I had a 3.5, almost 4-year-old, and also a 9-month-old, and it is hard. It is a lot of juggling, but if you are reasonably disciplined about keeping on top of your deadlines and working in a very mindful way, it is possible to do. So I would generally work exceptionally hard 9 to 5. Like, I'd be completing assignments during my lunch break and that sort of thing, and then it meant that I would have the evenings and the weekends free to be with the kids. But I do know other people in my course had a different experience, and they would perhaps be up at like 2 a.m. trying to finish an assignment that was due that day. So everyone's different in terms of their approach, and if you're reasonably disciplined, it is possible to do. Okay, our final question is, do they use straitjackets in mental hospitals? So for England, the answer is no. I can't comment on other countries just because I'm not sure. But in England, we don't use straitjackets. We have very strict rules on trying to use the least restrictive options possible. So, you're not admitted to an inpatient unit if they think that they can support you in the community. You're not restrained in a hospital unless they feel that it is absolutely necessary to keep you safe. So generally they will have done everything possible to kind of de-escalate the situation sooner and find alternatives to keep you safe, and would only restrain you in some way if they felt that there was no other option. And that form of restraint would normally involve someone holding you. So it might be that if you're perhaps repeatedly headbanging on a wall or actively, trying to harm yourself, that you might have someone holding either arm just to prevent you from hurting yourself. So it would always be someone holding you rather than things like straitjackets. And they would be aiming to do that for the kind of shortest possible time needed. And the fewest people needed. So they're not going to, have loads and loads of people kind of holding you down to the ground unless, they've tried everything else possible and that is the only thing that they can do to keep you safe in that moment. So yeah, it is something that I can understand, people would worry about, especially if you, watch the old films where, they had straitjackets and that's the thing, but that's not something that we use anymore. And yeah, staff should always be trying to use the least restrictive option possible to support you and keep you safe. Ideally, we would want to be on an inpatient unit noticing signs that you're getting upset or agitated, or be aware of your triggers, or times when things are perhaps you're more at risk of harming yourself, and trying to intervene as early as possible to keep you safe, rather than waiting to the point where things are more difficult and you are struggling to keep yourself safe, or you're actively harming yourself and intervening. Then we want to make sure that we're doing what we can as early as possible to help you manage before you get to the point of harming yourself. So yeah, no straitjackets. So I hope that's provided a bit of reassurance. So yeah, those are the questions that I've had so far. Do feel free to send other questions through. I'll put a link below of how you can send questions in, and then I will do my best to answer them. I generally can't go into lots of specifics, so about specific cases. So please don't send me your full medical history and ask me to decide what therapy you should have. But general questions about psychology I will always do my best to help with. So I look forward to hearing from you. Thank you.